Hi, welcome back to All Things Neuro. We are now going to talk about traumatic brain injuries, which is 11.A in your book, and concussion 11.C, because a concussion is a traumatic brain injury. So this is the best place to put it. Have your outlines. You have a separate outline for this content, still using that same giant PowerPoint. So, traumatic brain injuries, TBIs, major cause of disability and death in the U.S. By definition, any damage to the scalp, skull, meninges, brain, including neural pathways, cranial nerves, intracranial vessels. So we do have primary and secondary brain injury. So a primary brain injury is the brain injury itself. So I gave you a bunch of different explanations here. What I really want you to understand is coup and contra coup. So in the little JPEG I gave you, we've got a little boxing glove hitting the front of that brain. So that's my coup injury, and your brain actually moves inside your skull. So if you get hit hard in the front, your brain actually sloshes against the back of your brain, and that's the contra coup injury. So coup contra coup means there's two different injured area because of the movement of the brain. We do see what's called diffuse axonal injury, or DAI, and these are pretty devastating because it's all over the brain as opposed to one spot, which may mean that you have vision problems or memory problems or some speech problems or hearing or whatever it is. A DAI is a all over brain injury. We can have stretching, shearing, rotational, tearing forces. I've seen shearing injuries, which means part of the brain moves, like we'll move forward and then come back and you actually see a line on the CT. Concussions, mechanical force of short duration that's applied to the skull, and then contusions, which is just bruising. So secondary brain injuries occur after the initial trauma and cause damage to the neurons. It's an inflammatory response leading to cerebral edema. Decreased cerebral perfusion from hypoxemia, infection, and or fluids and electrolyte imbalances contribute to the secondary injury. And it's from hypoxia, hypotension, and uncontrolled increased ICP. Everything that we do as nurses to prevent. So we fundamentally should do our darndest to prevent these secondary brain injuries, because if they're hypoxic, give them enough oxygen. If they have hypotension, make sure they've got enough perfusion to that brain, and if I have increased ICP, I need to decrease it. So proper management should decrease the amount of these secondary brain injuries. Okay, so types of injuries. We've talked about some, so let's just talk about concussion. Mild traumatic brain injury, rapid onset with transient neurological impairment. They may lose consciousness for a short period of time. They may not. They do have alterations in mental status that last from a few seconds to a few minutes, but it's usually less than 8 hours. There's really no pathological change to the brain, and imagings don't show any changes. Usually resolve spontaneous with no treatment, but they do come in. We will do imaging, CT or MRIs, to make sure that we're not dealing with a traumatic brain injury. Do some assessment, and very likely to send these people home. So you do need to think about what you're going to tell the patient and the family and what they need to look for and be concerned with. There is a thing called post-concussion syndrome, which are concussion-like symptoms that actually show up between a week to a week and a half after the concussion. Nausea, headache, dizziness, fatigue, memory problems, difficulty concentrating, insomnia, light, noise sensitivities, personality changes. All of those are fundamentally signs of concussion. They're just occurring well after the initial concussion. Not real sure why they're having these. Can be some secondary, could be secondary emotional, could be some just pathologic changes because of that primary insult. And they usually resolve within a few weeks. Those with one concussion are at higher risk for a second concussion, even with less severe impact. So once you've had one concussion, you're at higher risk. Multiple concussions can lead to CTE, which we've already talked about with our encephalopathy and cognition. So it's important to know about concussions. It's important to assess for these. There is state laws I don't, it might be federal law that says specifically for youth, if they have some kind of head trauma during sporting events, they have to be taken out of that sporting event and they cannot resume play until they've been seen by a healthcare provider because it's such a big deal. And we certainly know that pro sports guys have problems because they've had so many concussions that they have neurological problems afterwards. And we've seen a few who actually stopped their pro careers early because of the risk for things like CTE. So treatment, we can give them acetaminophen. We wouldn't want to use NSAIDs because of the risk for bleeding, reduce stimuli, surgery to repair skull fractures if that is the case. Any new, if they didn't have nausea and vomiting and now they do, that is a sign. We're not going to teach parents and loved ones to look for and check pupils the way we do. We should teach them, however, if they look at their loved ones and their pupils are not the same size, that is concerning, that they need to bring them back in. But we're not going to teach them to use a pen light the way that we do. Basilar skull fractures are important to understand. This occurs at the base of the cranial vault, and you will see battle signs and raccoon eyes, so bruising behind the ear, or postocular ecchymosis, and periorbital edema and ecchymosis is raccoon signs. That is tearing of the meninges, and they will have CSF leaking from their ears and their nose. And so it's important that we assess for it. So we will do the halo test, let it grab that drainage onto a 4x4, might very well be bloody, which is what you see in the picture. And we're looking for the halo sign around that, which is the glucose leaching out from that. And that is positive for CSF. And you absolutely never, ever put NG tubes in these patients because it will go into their brain. Intracranial hematomas, we all know what a hematoma is. So there's different kinds. We can have an epidural. Those are from aneurysms, blow to the heads. They can sometimes go in, take those out. Sometimes they're not big enough that we worry about them. We do get subdural hematomas. It's real common to see people come in with subdural hematomas. These can be from trauma, from strokes. And we do have different categories. We have an acute, which happens within 48 hours, subacute, which is 2 days to a couple of weeks, and then chronic, which is longer than 2 weeks to several months. And those at risk for chronic subdural hematomas are the elderly or people on anticoagulant therapy because of the risk for falling and bleeding. Chronic subdural hematomas in a child would also, I would suspect, child abuse. And then we can have intracranial hemorrhages, and we do see those as well. I will say that sometimes when we talk about stroke, those are sometimes called intracranial hemorrhages and not strokes. Don't know why the providers do that, but sometimes they do. So let's talk about assessment management. So our goal is to manage the ICP, maintain the CPP, and prevent secondary injury. Okay, sounds like stuff we already know. One reference for this did talk about medical treatment, which is reducing ICP, and we're going to talk about that we've already talked about how we do that nursing wise. We're also going to talk about that pharmacological wise, maintaining airway and providing oxygenation. These people may not be able to maintain their airway, protect their airway, so they might be intubated. Maintain that CPP. Remember, CPP is mean arterial pressure minus ICP. It should be 70 to 100. Normal ICP is 0 to 15. Prevent secondary brain injuries, give them nutritional support. They will have accelerated catabolism and excess nitrogen loss, and they can lose lean body mass, so it's important that we feed them, so we need our dietitians on board with us. And that is just important. So let's talk about assessment. Airway, oxygenation, Glasgow Coma Scale. That is done hourly. We need to know their baseline, because if they have dementia, a former head injury, or a stroke, we need to know the patient's baseline so that we are measuring what we see against their baseline and not the baseline that we think of, maybe a Glasgow coma of 15. We're going to look at vital signs, ICP, CPP, hemodynamic monitoring may be done, history of the accident, the injury, any medical or family history. If this patient has dementia or has history of hepatic encephalopathy, we need to know about those kinds of things. Diagnostic test results. These are the same as our increased ICP patients, and we're also going to look at ICP. So our management, we will actually keep the ICP between 70 and 90. I'm using a different reference for this for you because we need to have enough blood flow to the brain and keep that CPP and ICP where we need it to be. Prevent those secondary injuries is important. All right. So we need adequate oxygenation. So we need that PaO2 over 80. We need our PaCO2 35 to 45. We need an adequate H&H. If my H&H is low, they need a blood transfusion. We're going to diurese them to decrease their ICP and increase their CPP. We need optimal fluid administration. We need blood pressure management. We're going to reduce their metabolic needs, temperature control, sedation. We may neuromuscularly block them, so we're going to give them a paralytic. And if you ever give a paralytic, you have to give them sedation. You have to turn that brain off. Never, ever paralyze a patient without giving them sedation to turn their brain off, because if not, that's like locked-in syndrome. Their brain works, they can't respond to us, and that is just mean, and actually you're going to make them worse. We're going to do seizure precautions, and we will actually prophylact them for seizures. We're going to position them to maintain that ICP and CPP, all of these things that we have talked about, prevent complications from immobility, tubes, lines, drains, nutritional deficits, surgery, which will be a craniotomy, take off part of that skull to allow swelling, and psychosocial support for both the patient and the family. Collaboration, our healthcare providers, our neurologists, neurosurgeons, pharmacy, respiratory, PT, OT, speech, rehab. Every time I think of stroke, brain injuries, I think PTOT, speech, rehab. My patient may not need those. They may not qualify for those, but my brain goes right there. We may need spiritual care because we may have poor outcomes from this. Case managers, social workers. So let's talk about pharmacological therapy that we're going to give. I've already kind of really talked about some of these. So IV fluid, we will use isotonic fluid like normal saline. We're going to avoid hypotonic solutions. To decrease ICP, we're going to give them osmotic diuretics like mannitol. It does come from 5% all the way up to 25%, so be sure that you get the right percentage of mannitol and give the correct medication. It's a diuretic, so I expect their ICP to come down, their neurostatus problems to get better, and I expect them to have increased urine output. We could also do loop diuretics like furosemide or Bumex. We may also use 3% saline, so a higher concentration of sodium to pull off that water as a higher concentration of saline would do. We're going to use anticonvulsants like Keppra and phenytoin and fosphenytoin, antipyretics, muscle relaxants, paralytics, blood pressure medications. The two most common things that we're going to see is labetalol and nicardipine. Labetalol, of course, is a beta blocker. Nicardipine is a calcium channel blocker. Both of those help to maintain normal CPP and are given as IV drips in the ICUs. And we need to have them on some stool softeners because we don't need you to strain. Surgical intervention is that craniotomy where we take that skull cap off. You'll see a note over the patient's bed that says the bone flap is out on the right, which means that skull cap is off on the right. It's put in the freezer in the OR and left there till that swelling goes down. It'll actually get concave and they put it back in. If it's too damaged from trauma, because they had such a significant skull fracture, we may actually put a titanium plate in there. It's important that we take this off so that we can allow for swelling, because we know the brain's going to swell. So you have to think about that there's nothing other than skin now covering that brain, so you do not want to place the patient lying on top of that bone flap. You don't want the patient poking it. You can gently touch it if the nurse allows you to do that, but you don't want to poke on it. If it's really tight, then you know we have a lot of swelling. And we're doing this to make sure we have a normal ICP and normal CPP. We need to monitor that dressing. If they have a ventriculostomy drain, we need to take care of that drain as well. So complications: edema, hemorrhage, obstruction of normal CSF, and infection. So we want to make sure that we don't have any of those. All right, let's talk about lifespan considerations. This was the best place to kind of put this together. So if we're dealing with infants, we're going to do what we talked about. We're going to measure that head circumference. We're going to assess those fontanelles. And you need to know when those fontanelles close. One closes fairly quickly and one takes a little bit longer to close. Abnormally large head circumferences with fontanelles that are spread apart are indications of increased ICP. Other signs: bulgy fontanelles, cat-like cry, weak or absent cry, irritability, lethargy, loss of previously acquired motor skills. Increased ICP is often a result of child abuse. We will talk more about that in Module 4. Shaken baby syndrome, or it could be congenital hydrocephalus. So it could be a congenital problem, so we need to ask those questions. Could be signs of abuse, and we need to take the appropriate steps. Positive Babinski reflex is abnormal in kids that can walk or anybody over 2. Toddlers and young children will have changes with their previous development, fine, gross motor skills, verbalization, behaviors. So we need to know what they're doing, so get a good history and what's appropriate for their age. The primary cause of concussion and TBIs is actually falls, motor vehicle crashes, accidental strikes to the head, assault or child abuse are the other causes. Injury patterns depend on the cause of the injury. Falls are usually local contusions with edema with that contra coup injury. Treatment and treat, monitor infants and toddler is similar to the adult. There is a modified Glasgow coma if we're dealing with infants who cannot respond verbally, so we will want to use that. Infants and children respond different to pain than adults. We need to talk to the parents and find out what's their normal activity, and have they seen changes that could indicate that damage and how they're responding to pain. And parents can also let us know how they're responding to pain, what's normal for them. They could have changes in sleep habits, seizures would be a bad sign, becoming easily upset, lethargic, uninterested in favorite toys. Those types of things should alert us. Children and adults: falls, motor vehicle crashes, unintentional blunt trauma, sports-related injuries or assaults are the most common. Primary secondary injuries are similar to adults. Children are more likely, though, to have diffuse swelling after TBIs. Some children, especially very young, may have difficulty describing their injuries or their signs and symptoms, so we're going to have to look at things that we look at more in infants and toddlers to assess for that. Your book literally says adolescents present unique challenges in preventing traumatic brain injuries. They're excited by danger. They like risky activities, perform tricks on their bikes and skateboards, play full contact sports. They like to drive too fast, and drug and alcohol certainly increase the risks and this risky behavior. Adolescents may also not report their injuries for fear that they can't participate in sports or that they might look weak. And so here's our legislation about those concussions. Pregnant women, basically you need to assume that all women of childbearing age could be pregnant, and we need to rule that out. We certainly need to stabilize mom first before the fetus. Late-term pregnancies might indicate a need for emergency C-section, and moms who've had a TBI will need additional support once they take that baby home. Older adults do pose some problems. There are some normal neurological changes associated with aging, memory loss, subtle loss of coordination, slower or diminished reflexes, some sensory changes. Highest risk for hospitalization and death to TBI is really results of falls, and the prevention of falls is key in preventing them from having TBIs. Worse, they do have worsening outcomes if they have pre-existing conditions, polypharmacy, and they are susceptible to lots of complications. Certainly falls that lead to hip fractures, which decrease independence and have high rates of poor outcomes. Signs of mild TBI or concussion can be similar to dementia, making it a little difficult to recognize. Certainly, if they fall and take an anticoagulant, they have a much higher incidence for intracranial hemorrhage, and we need to monitor for that. And rehab should start as soon as possible, and this is saying even in the ICUs, because that's important for us to start that process to hopefully get them back to living independently. All right, that ends our TBI and concussion recording. Thanks.